Now I would like to introduce Alan Jansen. Alan Jansen is a Senior Deputy Director of Behavioral Health and Developmental Disabilities Administration, say that 3 times fast, where he oversees services in Michigan for those with behavioral health and developmental disabilities, including those with autistic or autism spectrum disorder. Mr. Jansen has been engaged in Michigan's public mental health system for nearly 4 decades, so he's our process expert. He began his career as a case manager in Michigan's first assertive community treatment team, where he discovered his passion for community inclusion for adults who were experiencing mental illness. He eventually moved into several senior leadership roles within Michigan's provider network with a focus on designing and implementing residential and community-based services to better integrate clients into their community. As a former Chief Strategy Officer, Mr. Jansen worked closely with state lawmakers and MDHHS staff to improve clinical and policy practices. He also served as MDHHS as an interim director of Kalamazoo Psychiatric Hospital in 2014 before returning to the department in March of 2020. So welcome, Mr. Jansen, and we look forward to all that you have to tell us, and then call to action.
All right. Well, thank you for that introduction. I really appreciate it. So today I'm going to talk about the essentially 3 different things. One is the BHDDA, because I don't like to say it in full verbiage each time. Our department, I'm going to talk about the strategies we have been working on before COVID, a little bit about the impact of COVID. I really appreciate what the sheriff was talking about. You'll see from a bit of my data that is accumulated from across the U.S. that there's a strong correlation between the items he was talking about and some of the things that SAMHSA has discovered. And then at the end, I want to talk a little bit about strategies moving forward. I am fairly new to the department, so most of my experience at the department has been loosely around planning, but really crisis response to COVID. So I'm also happy to take questions. I tried to trim this presentation down just a little bit so that there was about 5 minutes at the end, but you also will see at the end a link to my email address, and I appreciate questions because we are in this together, and the more I can be informed by a reality, the better off I think planning efforts can be. So with that, let's get rolling on the presentation. And if we could have the next slide, please. So one of the things I like to do is just to remind people about the size and the scope of the mental health system that we're involved in. So you can see from this slide that we really channel about $3.5 billion into mental health, substance abuse, individuals with IDD, and autism services in the state of Michigan. A large part of that, of course, is Medicaid, almost 90%, with roughly then 9-10%. That's a combination of what we call general fund, which is really the state's participation in Medicaid as well as other general fund sources, and then some additional local match. You'll see that a big portion of these dollars go for mental health, which in this particular slide really represents everything but substance abuse services. Substance use disorder services, which is roughly just under 300 million of the 3.5 billion. And then lastly, if you look at the unduplicated number of clients, that's represented from 2019, our service sector, which is including all of you, really treats about 311,000 individuals in a given year. So that's the scope of who we are. We're delivered through the largely the community mental health system, which, as many of you know, is really where we begin with our first contract is with the our prepaid inpatient health hospital plans, which is there's 10 of those across the state of Michigan, and then they in turn are in partnership with the CMHs In some cases, that is the same entity as it is in Wayne and two other counties. And then we really have the primary relationship with the PHPs, but there are 46 community mental healths. All right, thank you. Next slide. So I'm going to talk a little bit about the priorities before COVID, and you'll see when we get to the priorities for this next year that there are a lot of things that are the same. So we really worked in this prior year, and to be honest, this was there before I came in March of this year. And as the introduction mentioned, I've been in the community mental health system for nearly 4 decades. In a variety of settings, but I did not specifically design this individual group of strategic priorities and progress. But again, you'll see a pretty strong linkage to what we have designed going forward. So we're working on the integration, of services. That comes through a variety of ways, but really, I think if many of you may have been privy to the efforts by the department, by the current administration, to redesign the way that services were delivered. And in that, there was a lot of values that were moved forward. And if you look at those, I think 8 values, number 1 is expanding the integration of the service delivery. And that really is based on a belief that if you integrate for the whole person, for services at the service delivery level, that you really have a better system. And those of you who provide SUD services have known that for a long time. The rest of us, I guess I could say, are catching up with you. So the next is to increase the access to the safety net psychiatric care. Again, there was a few projects for that. One, I'll just mention one, and that was there's something called a PRTF, and that is a psychiatric residential treatment facility, and that is a bridge between inpatient care and community care. It primarily is focused, this project was focused on the delivery system for kids, primarily with autism, to help have an impact on the state institution Hawthorne, but it is expanded beyond that. And even though it was stalled in this particular year, you'll see it come up in the next, in the future slide as well. So we were trying to bolster the continuum of crisis services. There too, what we're really trying to do is create a access to crisis services. So you'll see when we get to a future slide that there's something called MyCal, which is really a model of integrating all of the crisis delivery hotlines and information into one unified source. So that's an example. We're trying to implement the 115 behavioral health demonstration. I'm going to say more about that in a future slide, but that's an important endeavor for all of us as we move into the future. Continue to mitigate the substance abuse crisis or substance use crisis. I think that's probably of keen interest to all of you. One of the things we were working on there was integrating the information collection and sharing. I believe the name of it is eConnect, or eConsent, excuse me. But that also got stalled in this last year due to COVID. Trying to optimize the PHP and CMH financial and operational structures. I think that was really the focus of the redesign efforts. And since those are on a stall pattern, that one really, we did focus on trying to get some common rate setting moving forward. And that also stalled with COVID, but is now back underway. So that's the primary focus we're working on there. In addition, we addressed some contract inconsistencies across the system. So that's 2 areas that we focused on there. Strengthen the service delivery for persons exiting incarceration. A really important collaboration, which completely stalled during COVID, but it was picked up about 6 weeks ago again. And it's a collaboration between Michigan Department of Corrections, the Michigan Medicaid, and then the Behavioral Health Division at the state. And then lastly, promote self-direction and community inclusion for persons with developmental disability. That was largely focused on improving employment availability. That too, a lot of things with COVID really, we went into crisis mode, as you'll hear in a moment, during the last few months. And we were kind of coming up for air, and then of course we're in the second phase of or third of COVID, so a little bit of a stall there again. But that one will be picked up, I would say, as we move forward into next fiscal year. All right, next slide, please. Yeah, well, I think that's an understatement, right? COVID changed all of our plans. I like to tell the story that I started a week before we all went home. So I actually have not met many of my staff that are in the department in person. Of course, Teams is how we meet most of each other right now. So that's been my experience. I know that's modest compared to what all of you have experienced, trying to make sense of how to respond to and adjust to COVID. So we're going to go to the next slide. I'll give you some of the detail of that. So what I'm sorry, they got a little bit out of order, but that's all right. We can do this one next. So one of the things that we've found is that we've been trying to pay attention to what's been the actual impact of COVID. And I will tell you that what you see in front of you is indicative of what we've seen in Michigan. But because our data is largely based on claims data, we're a little bit behind. But we've seen many of early indications, let's say that, from some of our EDs and some of our crisis responders that many of the things you see here are accurate. So this comes from a study done by SAMHSA in August of this year, and it really was a review of all 50 states. So I don't think that any of you will be too surprised by these factors. So suicide rates increased by 1.3% for every 1% of unemployment. Now, while that's true, and we've known that for some time, we also don't know the compounding effect of isolation. I know those numbers will be worse. I just don't know how much worse they're going to be. The sheriff really, I thought, did a nice job of mentioning some of these next three areas. So across the United States, that the increase in anxiety and depression, and again, this is by clinicians, there's almost 31%. I think we have, it's pretty clear the trauma disorder issue is also increasing. And I think that's the one that's sort of a hidden issue, or at least we know it's there. We haven't seen the data to support it yet. I think the sheriff was alluding to seeing that as well. And then substance usage increasing. I think this is quite an understatement in terms of what we are starting to see locally. Those of you on this presentation know that I mean, you know it firsthand. One of the things we saw, and we stood up about 3 different access lines, and that doesn't include that all community mental health have at least their own crisis line. So we had, this is across the United States, 1,000% increase in the utilization of suicide and crisis lines. That's largely coming from the national suicide line. But I think we certainly, we noticed 2 things. The similar kind of increase. We also started up something we call a warm line, which is run by peers, peers broadly defined. And that has turned into be an incredibly strong link. So again, while it's largely not about suicide, it is really about intensive level of support for very vulnerable individuals. We have seen since April 9, when that line started, we have seen about 14,000 calls to that line. So very, very impactful. And now this is where I think many of you on the line know the reality of this. There have been a lot of operational problems at the service delivery level because of COVID. I mean, simply because most of us are paid on volume. The volume decreased. It doesn't actually get the equivalent in tele. One doesn't work in every situation, and the other is it's more limited. So there you see a pretty big impact. We're awful close to 100% of providers decreasing some of their service. We certainly have seen that in the state of Michigan. I think when we have done our quick analysis, we look at more of those in programs that are in a crisis, maybe are about to close or in jeopardy. And it's not as high as this, except there are individual programs that certainly have closed. We see behavioral health providers, as you know, a lot of our public system is not based on for-profit dollars and have not had the kind of financing to have a lot of money in the bank. That's not a universal statement, but it's largely true. And so this, I think, would be a pretty indicative of providers in the state of Michigan that the ability to go beyond 3 months is not very high, showing there at 37.9%. So again, when you start imagining this is across thousands, hundreds of thousands of providers across the United States, that's a pretty sobering number. And I think it's what drove the bipartisan pressure, the bipartisan decision for the CARES Act. And so I know we're all looking for the next one, but I think this is partly what helped drive the impetus for some of the flexibility in the previous CARES Act. This is an interesting finding. I don't know you can read it a lot of different ways. This is really just a raw perception of the number of folks who had their lives changed, which is a third of the folks receiving services. I think what we believe to be true, although I can't say this with any kind of strength yet today, is that we have a number of people that have in their isolation are likely to emerge for more intensive services really at any moment. And I will tell you, when COVID first started, the impact that we experienced for a variety of population groups was the ED, emergency department overload. Then it got mitigated. And about 3 weeks ago to 4 weeks ago, we started to see the first signs that the ED pressure had started again. So a variety of reasons for that. And I'll talk a little bit more when I discuss strategies in a moment. But we're starting to see that second surge have an impact on, again, really the front line, which is, or at least the crisis line. All right, next slide, please. So this is the one I did tend to do in between. This is really just the kind of things, again, don't want to spend a lot of time here, that we worked on. Whenever there's a crisis, the federal government has some models out there. Essentially, what you can do is the first three I'll just lump together. There are opportunities. Medicaid comes to the state of Michigan through a variety of waivers. Some of them are listed here. Appendix K is specifically available for crisis response. And really, if you think about it, it does 2 or 3 different things. There are lots of rules in Medicaid. These emergency authorities allow you to extend those, ignore those, or postpone those. And that's largely what we were working on in the first probably 2 months. You have to do that. Then you file it, and then the CMS makes a decision about whether they support what you've asked for. And we have been successful in all of those. Secondly, the second thing that happens is, and this is mostly built on situations like hurricanes. So it was a little bit of an odd fit at first. And that is, there's emergency counseling. That's what it's called. But emergency counseling program is got two parts. You get one almost immediately if you just ask for it, and that lasts roughly 90 days and allows you in normal circumstances to walk around face to face with victims and help them adjust, respond to, survive the whatever crisis has occurred. So it's a lot easier to imagine that in a hurricane or a flood. In our situation, of course, we couldn't go door to door. We couldn't get face to face. So it created a new conundrum for us, which I'm happy to say we worked with a variety of community mental health and PHPs to adjust to that. We were then successful in applying for the second grant, which is a 9-month grant, and we received that as well. But again, think about that as responding to any vulnerable population that has a crisis need. And we have counseling teams that are able to work with subject matter experts, or in fact are able to do that through telemeans. We started a crisis text line, which is unique for Michigan, got a lot of hits early on. And I have to say our best marketing is the governor and the lieutenant governor. Whenever they make a speech and mention the crisis text line, the volume goes up. So that's been really interesting to watch. Lastly, the legislature really did a nice job. I mean, they worked quickly to come up with $5 million to spread across all 46 of the community mental health. And essentially, you know, you never get money without strings, but the strings were not as typical or not as usual, and it allowed the community mental health to basically use their portion of the $5 million to respond to any COVID-related unexpected cost. So an important thing, and the legislature, I think, again, did their part. So let's move to the next slide. This is a placeholder. This is just to tell you, if you didn't know, that we have two places. If you go to this link, and this presentation will be available, so you'll be able to access it later. But this is a place where you can go where basically anything that we've done, which could be guidances, which could be policies, in some cases it's explanations, it's trainings, anything related to COVID and any of our activity, you'll be able to see there. All right, let's go to the next slide. So I see I got a 10-minute warning, so I'm going to have to go fast here. Thank you for that. So here's where we're headed in the future. I want to make one caveat. So one of the things we decided to do in the middle of COVID is, and many of you experienced this, because there was such a heavy focus last year on the redesign of the system, whether you believe that was a good idea or a bad idea, what it does in the middle of a crisis is it upsets the apple cart further than it needs to be. And what I mean by that is it brings in uncertainty, and we had plenty of uncertainty based on the issues going on with COVID and our response. So Director Gordon and I had several conversations about that, and in the end, a decision was made to postpone, is the best word, any efforts by the department for redesign. What he asked me to do instead was to create a list of strategic priorities that we would work on in this next year. So I will go through these quickly. CCBHC is an opportunity with the federal government. It allows you to create different funding streams. It integrates care. We're allowed to do up to 14 sites based on a previous application. That is underway. Expect that to be operationalized sometime during this fiscal year, or at least clear by the end of this fiscal year. You may, I'm sure you know about the health home expansions. That includes the opioid health home expansions. Really good numbers. I mean, really good integration and improvements coming out of that work. So I applaud all of you who are involved in the opioid health home or the behavioral health home. Strong belief. My very first presentation to the legislature was about the opioid health home. So if you'd like to see the data on that, happy to share that. But wow, it was impressive. Third, we're working on the psychiatric improvement. So I mentioned MyCal. We're looking at the bed registry so that if any of you have ever done work at a crisis center, you know that finding an inpatient bed is a really difficult thing to do. This helps that. Working on streamlining the medical clearance. I already mentioned the 115. I guess I don't have time to go into much more detail. If you would like that, certainly we can give you that. But again, there's the health IT plan, which I think is a huge step forward. We are looking at trying to create a really strong relationship between us and the delivery system. So that is altering or at least evaluating our policies and our operational oversight. So that's a fancy way of saying I'm looking at restructuring us to best meet the operational needs of the system that's out there. Third is really to look, and then there's an equivalent of that, is how do you manage that against the financial and the operational structures that are in each of the areas out there. And again, I apologize, I'm not able to give much detail here. With the KB lawsuit, that is a lawsuit about the services that children who have gotten in the state of Michigan, what allows us to rethink the way that we are structured at the state, and also so that we are focused on the whole needs of kids rather than the individual department needs. Again, I'm guessing because of the audience, you're very familiar of not being fully integrated into systems. And lastly, but not certainly hugely important, is that we know that there's disparities in the delivery of healthcare. And so the department's made a fairly strong stance, has asked each department to create our own diversity, equity, and inclusion plan. I am in phase 2 of that. Again, if anybody's interested, happy to do that later. With my 1-minute warning, I guess I had better just say that we have a disparities task force that's looking at where do we really fail in the state of Michigan in terms of our delivery. So there's some really interesting data that I think is worth looking at for any of you who might be interested. And I really apologize. I've spoken I don't normally talk quite this fast, but there we have it. And I think I will wrap it up for today. And thank you very much. You are very welcome to send me any questions. As I said in the beginning, please know that I will do my best to be responsive to you or one of my staff, and that I consider the work that you're doing imperative for the state of Michigan and the consumers that we are all working to treat together. So thank you for what you do. And please reach out with any questions in the future, since it appears we do not have time to do that today. So thank you very much, and I look forward to talking to you all soon. Bye now.
Thank you, Mr. Jensen. Welcome to your new job. I guess it is challenging, especially during this pandemic. I do, we don't have time for questions, but we certainly will send some to you, send them their way as we go along. But on your slide 2, you showed the proportion of resources and dollars that were allocated for services. And substance abuse is a tiny little, I almost couldn't see it.
I know.
And so I guess one of your charges as you're in your new position is how do we ratchet that up a bit? Because I think when we begin to talk about, one, the disproportionality of how this disease is impacting us, what are the lessons learned that we can apply to the resources that we have or don't have available in our communities to address SUD? The other thing is we met in many of the town halls with Director Gordon regarding the PIHPs, et cetera, and the restructuring. And part of our concern was where's prevention? Because if we don't go upstream and determine how we're going to address not only this pandemic, but the opioid and the other substance SUD issues, what are we going to do? So hopefully you'll apply those lessons learned. And I'm sure there are a lot of us out there that can, to help you in that effort if you ask.
I appreciate that. Thank you very much.
Thank you. Wow. I think that we are experiencing these unprecedented times, but I think one of the things that we have to do is to make sure that we apply lessons learned. The disproportionality of how COVID is impacting minority communities and urban communities and rural communities. These are things that we have to then go back to the drawing board and say, what do we need to do to continue to address the challenges that we're facing?